Hello, everyone. My name's Mallory Price. I think I've met a few of you on the attendee list. I'm going to be doing a webinar today about practical strategies for trauma-informed case management. Just to keep you in the loop, make sure that you are on mute, and Torlin will, from All Chicago, will also kind of keep track of questions. So as we go along, if there are any questions that come up, feel free to put those in the chat box, and there will be time after we go through the slides for us to answer some questions. So yes, please feel free to utilize that feature. And it is 1:30 right now, so we are going to jump in and start. So my name is Mallory Price. I work in I have my own private practice, a therapy practice in Chicago, and I have an office in Hyde Park as well. And I have, while I am doing private practice, I also worked for about 12 years in housing programs as a case manager, a manager, and then a director. I most recently worked at Chicago House, so I am very familiar with a lot of the things that you are going to be encountering working with clients and helping them transition from housing to homelessness, or from wrong way, from homelessness to housing. And so hopefully this will be a good review for everyone. And again, please don't forget to put some questions in the chat box so we can make this a little bit more interactive at the end. So first of all, the training will cover just a brief overview of what trauma is. Most of you probably already know, but just to go over some basics, and then we'll also talk about providing a framework for case managers to understand how to implement trauma-informed care into case management. And then we're going to look at some really practical strategies and expand your understanding on how to implement the trauma-informed strategies into the outreach, intake, assessment, housing process, and then just how to sustain trauma-informed care and that lens as you're working with clients throughout throughout your case management relationship with them, and then also even into when you terminate. So as we begin, I want you to all think about the most difficult client that you ever had, and I want you to keep that person in mind. I want you to think about what they were like and what were the things that made them so difficult to work with. And as we go through this presentation, I want you to kind of use that client to think about applying some of these concepts that we talk about so that it actually is a little bit more applicable to someone that you may be encountering in the future. So again, we're gonna start off with what is trauma. So trauma is essentially a normal reaction to an abnormal experience that someone has. And when someone experiences trauma, it's an overwhelming event, action, or condition. It changes the way that we see ourselves and how others see us, or how we see others and our environment. It also, we might be aware or unaware of these changes, that these have actually happened to us and this has impacted us. We might not have any kind of recognition of that. And also trauma also changes the impact, or has an impact, and changes our mind, our thoughts, our emotions, and even our body. There really are neurological impacts to trauma. So trauma can be a single event. So sometimes we call that big T trauma. That would be like a natural disaster or experiencing war. But then there also are little t traumas, which are often multiple events that occur over time, and those are much more complex. So those are things like domestic violence. So someone who is experiencing domestic violence for a prolonged period of time, some individuals live in and experience intimate partner violence for 30 years. And so that is an example of complex trauma. Also, child abuse is an example of complex trauma. And when people experience trauma, trauma really overwhelms someone's ability to cope and to integrate one's own experiences, ideas, and emotions with events. So in addition to big T and little t trauma, sometimes we don't always recognize the way that trauma is really impacting individuals. So there is overt trauma, which again is like natural disasters, mass violence, accidents, rape, sexual assault, physical assault, intimate partner violence, child abuse, community violence, but then there also is insidious trauma, and that is things like stigma, racism, inequality, poverty, classism, homophobia, transphobia, heterosexism, cisnormativity. All of those things are just as impactful at all of the insidious trauma that I've listed here are just as impactful as overt trauma that we might recognize more commonly. Those are the things that we kind of think of right away, but we don't always think of insidious traumas. And a lot of times, even our policies are embedded with insidious trauma. And then, as we said, the effects of trauma is that it literally changes your brain. So there is neurobiological impacts. People can suffer from social, emotional, or cognitive impairment. They might adapt some acquire some maladaptive strategies. They often have severe and persistent health and social problems, including early death. And then impairment in forming relationships is also impacted. And one thing that I'm going to emphasize here a lot today is that impairment in forming relationships is really something that we should be thinking about when we're engaging in trauma-informed case management, because an interpersonal violence or violation that someone has experienced in the past at the hands of an authority figure is really especially damaging to people, and it really impacts their ability to work with us and to form relationships in the future. And so it's important that we are sensitive of this because there is already an inherent power dynamic between us and clients. And so we want to be very aware of how that power dynamic plays out in our relationship, and make sure that we are not abusing that power that we have over clients as gatekeepers of services. And so when we think about trauma-informed care, we're thinking about really, I felt like this was a good definition. Trauma-informed care is a strengths-based framework that is grounded in an understanding of and responsiveness to the impact of trauma, and that emphasizes physical, psychological, and emotional safety for both providers and survivors to rebuild a sense of control and empowerment. So again, it's really a very interpersonal experience, and something that we need to be aware of the ways that our relationship with the client is impacting these things, and be sensitive of the history of the client and the things that have impacted them in the past, many of which we will never know. but to be able to be trauma informed, we really want to pay attention to these core principles, to have an awareness. And so we're aware of the role of trauma, but we're also aware of our power dynamic again. We want to make sure that we try to create safety, that we're trustworthy, that we give people choices, that we collaborate with them. Our clients are our collaborators. And so we want to allow them to share the power with us, because we want this to be, as the last one says, we want to emphasize empowerment. We want this to be an empowering experience. And why should we engage in it? Because trauma is relevant to all service providers. Some of us may have experienced trauma as well, and now we're providing services to others. Experiencing homelessness is often a traumatic experience, and it requires our attention and consistent support to treat people with understanding, dignity, respect, and respect that they deserve, and really honoring their experience. And so this isn't not actually something that, like, we can look at this sentence and it seems like simple, that of course we would want to be treating people with dignity and respect, I hope, if you're a case manager. But I think that it is really hard in the day-to-day, when we are struggling ourselves. And we can also be impacted by systemic trauma and personal trauma. And so it really is important that we are creating this consistency and that we are keeping strong in those core principles, and continuously thinking about them. When we engage in trauma-informed care, while it takes effort, it also will decrease our vicarious trauma and compassion fatigue, which we'll also talk about a little bit later in the presentation. And so trauma-informed organizations, programs and services are based on the understanding of vulnerabilities or triggers of trauma survivors that traditionally that traditional service delivery approaches may exacerbate. So really engaging in trauma-informed care and housing first programs is very unique. We want to make sure that we are not re-traumatizing people, that people are not having that same experience where they go to seek services and they're told that they don't qualify, or they have to be careful about the things that they say or modify what they're telling us so that they can actually qualify for services in the first place. When that happens, we're really shaming people, and we are not actually getting the services to the people who need them. And so as agencies, it's really important that we're being cognizant of avoiding re-traumatization and creating a corrective experience so that people can access services that aren't going to shame them and that are going to meet them where they are. So if you're thinking about it from an agency-wide level, you're going to think about making sure that you're incorporating trauma awareness, you're building safety with people, there's opportunities to rebuild control and empowerment, and that people are emphasizing strengths-based approaches rather than deficit-oriented ones. We're going to get into more specifics shortly, but I do want to talk about a few things that really are inconsistent with trauma-informed care. I also think that it's important to note that when we're talking about trauma-informed care, we're not talking about just being nice to people. That's not what trauma-informed care is. You can use a nice tone of voice to speak to people, but it isn't something that you're doing because you're just trying to like be a kind person. That can actually be detrimental sometimes if you're just trying to like be really kind and caring to somebody and you're not necessarily being very genuine. Because also we have clients who are survivors of sexual abuse. And so sometimes when you are working with someone, just because you're being nice to them, that doesn't mean that they're automatically going to feel comfortable with you. A lot of times people who have been abused had abusers who did try to be nice to them in the first place. So sometimes that can trigger things for clients that we are not aware of. And so it isn't just about being nice to people. It's about being, it's about holding these principles that we mentioned before, that we're trustworthy, that we're giving people choices, that we're collaborating, we're empowering people, and that we continue to have an awareness of how trauma impacts our relationship with them, and that we're building safety continuously. The building safety will never end until the relationship is terminated. Actually, even after the relationship, the case management relationship has terminated, because respecting boundaries is also an important part of trauma-informed care, and showing that you can create safety and not blur boundaries even after that case management relationship has ended. So, okay, so some examples of things that are inconsistent with trauma-informed care are going to be withholding services. So this is telling somebody that because they are raising their voice, that they aren't going to be able to have access to food or bus cards or be in a program. Not recognizing the power imbalance inherent in staff and client relationships, exerting your own will onto a client, or thinking that you're like doing something for their own good. But unless they have given you explicit permission in advance to do so, or to make a choice for them, we shouldn't be making choices for people or doing things because we think that it is in their own good. Trauma-informed care is about being client-centered and making sure that it is that client's choice what they're doing. If there are natural consequences to a choice that they make, then there will be natural consequences that they have to experience, but that is much healthier than someone else coming in and making a choice for them again in their life, especially if they've experienced trauma before. It's much better to let someone else have that choice and to learn from maybe mistakes, or there really aren't mistakes. Every mistake is a learning opportunity, and so letting people learn on their own without us trying to kind of like manipulate things. And it doesn't always come from a bad place. A lot of times we really want things to go well for our clients. We want to help them and support them, but it's really important that choice is not being taken away from them. Another thing is an insistence on being in charge. So when you're thinking about working with someone, if you are very particular about the way that you're engaging in case management with someone, and tell people that they can only speak to you in a certain tone of voice, or that they can only talk to you at this time when that is like convenient for you, but it's not actually like meeting them where they are, it is going to really replicate The power dynamics that abusers often use to threaten and intimidate people. And so clients are often afraid of staff members who are really invested in like being in charge, and they don't always feel comfortable with telling and being honest about what they're going through. And that's another part of trauma-informed care that is really important, is that that safety that we build with people allows us to, or allows the client to really feel comfortable telling us where are they, not telling us what we want to hear because we like they think that we are judging us, or that if they tell us something negative that they're going to lose services. It's really about letting people have honest conversations with us so that we can actually help people, real people, where they are, not where we want them to be, because we don't have time to listen to where they actually are, or we don't want to acknowledge where they are, or let them be in that place. So, and then also when you're working together, you sometimes people will make like behavioral contracts, but this is not necessarily talking about like behavioral contracts. This is just kind of like the contract of being engaged in case management. So, but it is a two-way street, and it's really important for us as providers to make sure that it's not just the client that is responsible for being consistent or being or following up with things, that it also is really our responsibility as well. And so we want to make sure that we, if we say that we're going to do something, that we do it. If we say that we're going to do something and then we don't do it, that we own that and actually have a conversation about it. And that we don't pretend like we didn't make a mistake, because everybody makes mistakes. And really having a trauma-informed or engaging in trauma-informed care in the case management relationship is a very therapeutic intervention. And it is something that we want to look at as we're teaching clients how to work with other people and how to communicate and how to have healthy relationships where there can be conflict or people can make mistakes, and you can work through those mistakes together, and not everything is lost. So we also want to make sure that, especially in Housing First programs, that we're supporting people as they become housed and start to heal. And that when we are working with people, again, we're not like taking a deficit approach. We're asking what happened to you, or we don't even need to ask that actually explicitly. We can just create an environment that is allowing us to ask what has happened to you instead of what is wrong with you. And that we are understanding that past trauma can be triggered by experiences in the present. So some of you do outreach, and things that are really important when you are doing outreach with people is that you are being non-judgmental, that you're providing that choice, and that you're listening to what the person wants for themselves, not what you want for them, and that you have realistic expectations in terms of what you can provide. So if you go in to an outreach situation and you tell someone, help me fill out this form together and we will get you housed in like a month. That's probably a bad thing to say unless you are like 100% sure that there is somewhere that person is really going to be housed. you shouldn't set unrealistic expectations for what you can provide, because sometimes housing does take a long time. You also are not necessarily going to be able to find them a studio apartment on the north side in their favorite neighborhood. And because unfortunately, housing is very costly, and the fair market rates have skyrocketed. So being able to get somebody a nice studio on the north side is not going to be something that is probably super realistic. Some people might have connections, and that is wonderful. But when clients are asking for those things, you want to be honest with them. You want to say, if you can try and you know one landlord that it may be possible to get them a studio on the north side, you can say that. But also explain that that may not be an option, unfortunately, that is something that you would like for them to be able to access, but that isn't something that this can really provide right now. And it may not be able to, you may not be able to provide that in the future. And let people make their choices about that. And also don't assume that immediately housing someone is the end all be all solution. So sometimes when we are doing outreach with people, we set up kind of a narrative that, like, if the person gets housing, then it's going to like change their life, and they're going to be so grateful that they have a place to live. But there's also a lot of loss in being housed, and so acknowledging that is important. Because sometimes, especially, I remember working with a client who was doing a lot of like panhandling, and that was a really important component of his life. Once he was housed, things kind of started to go downhill in a way, with his, because he no longer had his social support network. And so being honest that this is not an easy thing, being housed, or like getting on a list and waiting is not something that is going to be a wonderful process to have to go through. But we can walk through that process with them and do what we can. We can't wave magic wands and make miracles happen, but being realistic about what you can do is important. And also saying what you can't do, but not telling them, I can't do this because I don't want to do this for you. Explaining why and giving context as to why that is not possible is really important. Also, you want to pay attention to the language that you use, especially when you're doing outreach, because you're not even going to get to the point of doing an official intake with somebody if they don't feel comfortable with you. So you want to make sure that you're respecting people's pronouns, that you're asking what people prefer to be called, and that you also are not using like a condescending tone, or being annoyed or aggressive, or being too assertive to someone. You want to be able to set boundaries, but you also don't want to make that person feel intimidated. And you want to remember again that exerting control, or exerting power, control, or expectations over a client can be triggering to those who have experienced trauma. And so if you think that you do this, none of us are perfect, but if you think that you do this, then you probably want to take a step back and really work with a supervisor, or even do your own therapy to make sure that you figure out why is that happening, and make sure that you're not taking out maybe your own trauma on clients. Okay, so again, in the intake process, we want to set the stage for healthy conflict management. So you want to be very explicit and make sure that you're building a environment that is comfortable for people. So when I would do intakes with clients, I would always talk about how if they felt angry at me or upset or wanted to like drop out of services, that those were feelings that sometimes people have, and I could be doing something wrong. And it is really important that they let me know if they feel that way, if they can. If they can't let me know that, then they can always let my supervisor. But that it is important so that we can continue working together and that we don't have people drop out of services, that we have a good relationship together. And if there is something that I do wrong, then I'm held accountable, and that they let me know. And if there's something that they're struggling with and they get really mad at me and they tell me F you, that is completely okay that they told me that. I'm not going to argue with them and tell them that they're being disrespectful, because that shuts down the conversation. And that is probably what a lot of people have done to them in the past. And it never solves any of the issues around healthy conflict management. So if someone tells you F you and they get mad at you and yell, talking about it before that actually happens is really important, because then you say to them, sometimes you might feel angry, and if you say that to me, I'm still going to be here. I'm still going to be a consistent, trustworthy, reliable person, and I'm going to let you take your space and calm down in whatever way that you need to. I'm not going to tell you how to or when, but I'm going to let you have your space. And then when you're ready to talk to me again, we can figure out better ways of how we can work together in the future when you're feeling upset. And that doesn't have to interfere with our relationship and me helping you get housed or empowering you to reach your goals. And so if I was operating from a non-trauma informed care perspective, and someone said F you to me, I could maybe get mad and angry and tell the person that they're being disrespectful and that this isn't how they're supposed to get housing. And when we do that, we really shut down that relationship, and we don't allow for that healing to take place and for people to actually get access to the services that they need or learn new skills. And a lot of the times when people when people are triggered, it's not like they're making a choice to lash out. Sometimes it is a trigger that they're not even really aware of at that point. And so us kind of helping connect them with a therapist or helping connect them with supports and working through that conflict is vital. And then I really feel that the intake process is the most important part of any kind of like relationship, because you really are setting the stage for what it will look like going forward, not just with conflict, but also by explaining them their rights. So as you go through paperwork, sometimes, yes, you have a mountain of paperwork that you have to go through with people, but really going through and naming what their rights are and reading the paperwork so that they're aware, affirming that no one is going to intentionally discriminate against them on the basis of race, sexual orientation, gender identity, any of the things that it says in your paperwork. And if they feel that way, that someone has discriminated against them, then they absolutely should let someone know, because that is their right. And we want to empower people to know that that is their right. We're not empowering people to get mad at us and tell us all of the things that we're doing wrong. Some people get afraid of that when we're saying about encouraging clients to know what their rights are or to file complaints or grievances. It actually is a really healing thing, and it allows you to have healthier relationships and communication with a client when they know that you actually do respect their rights and you respect them as a person. And that these are things that if you make a mistake and you say something that is like offensive or upsetting to them, that's something that they can communicate to you is offensive or upsetting. And if they say something to you that is offensive or upsetting, you could also try to use this as a tool, like use this conversation as a tool to explain and work on some skills around that. You also want to acknowledge that just like everyone, we are all people. We will make mistakes. I may make a mistake and put down the wrong time that we're supposed to meet, or they might make a mistake and forget that we had a meeting when I come to their house. We don't want that to happen every time, of course, and you can say that, but you want to really set what the expectations are of your relationship during the intake process, and let them know that you are a collaborator, that you're not someone who is out to get them to make sure that they're doing what they should be doing. You want to make sure that they know that you are really there to support them throughout this process, and that someone is on their side and rooting for them, and that they will make mistakes, and that's okay, but preserving that relationship and being able to keep them engaged in care and letting them have honest conversations with you is really important for them to be able to remain successfully housed once they are housed. And then for the assessment stage, you want to remember that when someone tells you about substance use, homelessness, sex work, or even theft, that they're telling you how they have been surviving. They're not telling you, like, they're not just telling you all of these deficits about them as a person and all the ways that they've failed. They're telling you the ways that they have been resilient and have been able to survive. And so the assessment process is really it's a really vulnerable time for a client, because we are kind of asking them all of these questions about who they are as people, and many people have already judged these things about them, and so we want to make sure that we are not doing that. I try to always, when there are in-person trainings, I try to always ask everyone to unlock their cell phone and to think about handing their cell phone to the HR person at their agency and allowing them to look through it. That is kind of what an assessment is like for some people. So someone is essentially like, it would be like you unlocking your phone and handing it to HR so that they can look through all of your pictures and your emails. And sometimes when people go to shelters, they're handing over their phones. And this can be really violating and triggering to people. And so we want to be very, aware of that during the assessment process, especially like when we're doing psychosocial assessments. We want to explain why we do those assessments. And if we're doing them every 6 months, explain why. So a lot of times it's because we have to gather data. It's also so we can check in on how they're doing and make sure that they are getting all of the services that they need. But we want to make sure that we don't just say we're doing this assessment. We should be explaining why. We also want to be non-intrusive and let them know in the beginning of doing an assessment that if there's a question that I ask, that you don't feel comfortable answering, that's okay, and you don't necessarily have to answer that. So when I say that, some people are like, oh my gosh, how can we tell a client that? Because my boss isn't going to be happy if there's a blank line on the paper. But writing that the client didn't feel comfortable disclosing this information at this time is 9 times out of 10 okay. And so working with your supervisors around that, but still giving the client the choice, so that they don't feel like, if they don't feel comfortable right away providing this really sensitive and personal information, that they don't have to, because that can be re-traumatizing. And then you always want to just make sure that you're patient and non-judgmental. Answers are not always going to be clear or chronological. You're not trying, when you're doing an assessment, you're not, like, your goal should not be to try to find where the client is like messing up and telling us inconsistencies. There may be inconsistencies, but we're just trying to learn who this person is and how we can best support them. We might not know everything about who they are until much later in our relationship with them. But you're going to learn less about who they are if you're impatient and judgmental in the beginning, and you probably are also not going to have that person as a client for a very long time, because they're not going to want to work with you. So, and you want to let go of the idea of certain expectations or achievements that people should be making in between assessments. So if you're doing 6-month assessments and goal setting, and if someone didn't like achieve a particular goal in between those assessments, that probably means that the goal that you set for them wasn't where they were. So we want to think about the stages of change, and we don't want to say it's because this person is lazy or they don't care. We want to really look at, are we setting them up for failure and setting goals with them that they actually can't achieve? Maybe we need to start somewhere smaller. And so really being mindful of that and not trying to look at assessments as you're assessing that person's productivity in the world, because that's not really what our job is. And as you're going on with the housing process is extremely stressful. I know you try to work with landlords, you got to wait for checks to be cut. You are constantly trying to find where your client is, get a hold of them, especially if they don't have a cell phone. It's very difficult. But you want to acknowledge how stressful the housing process is in the beginning. And you want to talk about how sometimes you think you got that apartment, and you're working with someone, and we think that they're going to move in next week, and then you get a call from the landlord and they decide that they're not going to work with us. And so there is a lot of disappointment, and in making room for that and room for the feelings that are associated with that disappointment is really important. You want to always make adjustments to help that person succeed in the housing process. So you're not going to tell them, I need you to be at 115th and King Drive when at 6 p.m. when they get off of work, or when they have a case management appointment with you on the far north side at 5 o'clock, because they're probably not going to be able to make it. And so you want to make sure that you're helping that person have goals that are achievable and not just setting them up for failure over and over. You want to validate their emotions, that they're going to be frustrated and be upset with this process and feel like maybe I should just give up because I've been homeless this long, and this is not an easy process to be housed. You also want to make sure that they understand what their rights are in the housing process and as a tenant, and giving them resources and explaining how things work, what their rights are and what their responsibilities are as a tenant. And then also discuss what will be lost after being housed. So if they were used to sleeping on the CTA and talking to people, like the same few people every morning, that could actually be really important, a really important social interaction for them. And now they could be housed and not feel like they have anybody to talk to. And so there are things that can feel lost and that people need to adjust to, and you want to be sensitive of that, so that isn't really that in case that triggers some past trauma, that we're aware of that and that we're working through that. And then we also want to talk about how avoidance is sometimes an initial reaction that people have. They want to avoid things. Sometimes we will say that they're self-sabotaging, but there's a reason why it is scary for some people to be housed. It is scary for people to work with service providers because they have had bad experiences in the past. And so acknowledging that that sometimes they might fall off the face of the earth and we have no idea where they are, we should anticipate that that will happen and talk about what you should do as a case manager if that happens in advance, so that you know how to continue to like be in contact with this person, even if they feel like they want to avoid you, or if they are really struggling with following through on the steps of the housing process. And then when you are working with someone long term and you have that engagement built in and you're monitoring their progress, you want to also acknowledge and recognize attachment patterns, because there is unfortunately a good amount of turnover sometimes in case management. And so you want to talk about what it would be like if you were no longer their case manager, and the things that you can realistically work on together, and how trust is built, and at all times, whenever possible, that you are really helping them if there is a transition in the case manager, that you're helping with that transition and you're not just dropping someone off into another case manager's hands and they have no idea who this client is and the client has no idea who they are. And you want to make sure that you're remaining consistent, predictable, you create routine and structure. When you say that you're going to be somewhere, you should show up. You should also make sure that you're not just popping over to people's houses. I know sometimes we want to do that if a client is not engaged and they're kind of falling out of care. But we want to talk about that in advance and make sure that that's kind of their choice, that they want you to pop over and find them, because it also can be kind of violating to them. And you want to be aware of your own reactions and expectations at all times. And you want to allow clients to have control over the things that they're able to control in the situation. So you want them to be able to have a choice. I know we usually show people maybe 3 units and that's the max, and show them they have to make a choice between usually like the 3 units. We shouldn't be making that choice about which unit that they decide to go into, even if it's a unit that we're like, oh, this is an amazing unit and we want them to live there, we can't make those choices for people. We need to let them have control over those things themselves. And also control over what goals that they set for themselves. And over just how they start to build a life in the new environment once they are housed, and how they will sustain that. That's not really up to us. Those are all choices that they should be able to make. And so a lot of times we do have some difficult clients that we will encounter, but it's really important that we're thinking about client behavior as coping and survival skills. That sometimes when people get angry, we don't like the fact that they feel angry. But we want to make sure that we're validating that we acknowledge that anger is a valid emotion that people can have, and that is okay. Being hostile is very different than being angry. But being angry is okay, and that we can work with people who have a range of emotions, and that we can help them develop coping skills and work with us as providers to help them get where they want to be, and hopefully over time decrease that anger or frustration. But just because someone is angry, that doesn't mean that they don't also deserve to be housed, or that we shouldn't kind of try to identify where that anger is coming from and work with them from there, because otherwise they're just going to keep going from agency to agency to agency, and people are going to keep passing them along, and they're never going to be housed because nobody is interested in working with them because they present as like angry and loud, and it makes people uncomfortable. It's our job to kind of try to engage people and make sure that we're not invalidating the fact that they're angry, that they've been passed around from agency to agency, and people will say that they can help and they don't always help. And so that's an important thing to really validate for them. And then when you're thinking about termination, sometimes we terminate by choice, like maybe the case manager is leaving, like I said, or sometimes, and hopefully it's a rare case, but sometimes we do have clients who involuntarily discharge. They drop out of care with us, but we don't want to, just because they're not necessarily like following the rules and the responsibilities that they agreed to maybe in the case management contract, that is their choice. We want to try to support them and help them recognize the benefits of being housed, and the benefits of following the rules or working with a landlord, even if they're a really horrible landlord. But we don't want to shame people or try to tell them that they don't know what they're doing, even if they are engaging in maybe self-sabotaging behavior, or what we would view as self-sabotaging behavior. That doesn't mean that they don't still have the right to services, and they can, and like we might have to involuntarily discharge them so that someone else can get housing, especially if they've like kind of disappeared on us. But we don't want to completely close that door. Sometimes agencies do have policies in place, and they aren't going to let people be rehoused with them if they've dropped out of care. But it hopefully your agency is not like that, because sometimes people just aren't ready and at that point yet. And so we want to make sure that they know that we are still a safe organization and that there are case managers that are going to provide them with the support that they need when they are ready to be housed. And then you want to acknowledge if you are terminating with someone and say you've worked together for a really long time, you want to acknowledge that it is difficult for them to see you go as a case manager if you're leaving and moving into a different agency or position, and not pretend like that isn't something that has been important and helpful to them. And you want to give them the space to talk about it. And then you also should be understanding if they seem a little bit distant towards the end. If you're telling them that you are terminating, that's something that maybe that they're really having trouble dealing with, but they don't want to tell you. And so just being like cognizant of that and giving them the space if they feel comfortable talking about it is also an important thing to do. So yeah, we want to, in general, just make sure we're validating people's experience, that we're looking at the settings that we are working in and making sure that they're safe for people. If it is an inappropriate time or place when you're trying to like talk to a client about a particular skill or something, you don't want to embarrass them in front of other people. So you want to be conscientious of the ways that we respond to people. You don't want to say something rude or like try to work on a skill in front of a landlord or maybe in the middle of an office. You want to bring them to the side and respect their privacy and also just try to maintain consistency in your relationship. And you want to listen. You might also want to ask for feedback on a regular basis as well, because that is really important and that gives the client some ownership in the relationship between the two of you, and they can also get to a point where they ask, are there things that I can work on? And that is a wonderful thing, to be able to ask someone how you can be a better case manager, and for them to also ask like what else can they do, and because they trust you and they want to know what other things are possibilities for them to work on. Okay, and then you don't want to ignore vicarious trauma. So vicarious trauma is when we ourselves as providers are listening to trauma or see our clients that experience trauma and then they're reporting that to us. That can really impact us. And so we always want to be very aware of that throughout this whole process as we're engaging in trauma-informed care and be continuously reflective. Because if we don't take care of vicarious trauma and really address it, then we're going to start to experience compassion for fatigue or burnout. And so, yeah, you want to monitor yourself, take care of yourself, take time for yourself, make sure that you're separating yourself, that you're not available 100% of the time on weekends. That doesn't mean that you're a good case manager just because you're available 24/7. Being consistent with your availability is much more important than being available 24/7, because you need to take time to take care of yourself. And then you want to be able to help yourself and be honest with yourself and do what you need to do in your personal life to put you first, so that you aren't getting burned out, because this is very dealing with people who have experienced a lot of trauma. So, okay. And then if we'll go to questions. Just if we don't get through all of the questions, or something comes up later, this is my contact information. If anyone would like to contact me, ask any questions, or follow up on what we've talked about today. So, Torlin,
Yes.
hi. Okay, do you have some questions?
I do. One of the questions is vicarious trauma the same as secondary trauma?
I would say no. It kind of, so when you're saying are you the person that's asking this about secondary trauma?
No, there's a member of the attendees.
Okay. Usually secondary trauma is like when you have experienced trauma, like not as necessarily as like a service provider. Vicarious trauma, it is usually that you are in a role and providing services to someone. Secondary trauma is something that maybe like if you are friends with somebody and you like know that someone's family member was murdered, you like also have feelings and reactions to that. Not that you don't as a provider as well, but you also can disclose those feelings in a way that maybe someone else that is not serving in a role and doesn't have that kind of power dynamic with a client experiences. And so vicarious, I would say like it essentially that they are very similar. But like when we're saying specifically like vicarious trauma, it's more about the provider like being in the role of a provider, and that there is that power dynamic and imbalance that creates the vicarious trauma through your interactions, like through doing your job, really.
Okay, thank you.
Mm-hmm.
So,
Mm-hmm.
so what are some additional strategies? This is a question that I have, Mallory. What are some additional strategies in terms of as you're evaluating and you're especially doing COVID-19? Is there some tips or some best practices you would suggest to the audience about now that, I mean, as you know, COVID, as the pandemic continues, is there anything that you would kind of want to share with us additionally, maybe on the topic to aid us or give us some type of guidance?
Sure. So I think that it's really important, especially right now, that you are being sensitive of how clients feel about what is going on with the pandemic. It is a very real possibility that they could get sick, that they know people who have gotten sick or even died. And so you want to make sure that you are conscientious of giving them that choice about like where they want to meet, or how close they want to get to one another, and when they're filling out paperwork, what is going to make them most comfortable in that process, because it can be very stressful and anxiety provoking to have to be in a situation like that. And I think also something we talked about before, some people might be on this webinar, when we talked about a month ago about strategies, and something to think about is really trying to help people decrease their anxiety by thinking about the things that they can control. And because usually anxiety is produced when people have the sense that they don't, or like they have the feeling that they can't cope with something. And so if they feel like that they don't have the coping skills, then then their anxiety level is going to increase. But the more preventative measures that they can take, and the more that they can focus on what they are doing and what they can control, the lower their anxiety will be.
Thank
Go
you.
ahead. Mm-hmm.
No, thank you. That was very good. Thank you so much.
Yeah. Yeah, and if anybody has any other questions, please feel free.
Yeah, so let's give people a couple of minutes and see if you have any other questions that you can put inside the question pane for Mallory. We'd appreciate it. So one of the questions is, as a provider, any self-care tools to help providers from bringing client traumas in our lives?
Sure. So, I mean, I think that something that's really important at the end of the day is that you're taking even 5 minutes for yourself to check in. I know that sounds like something that is so simple to say, but it is very difficult to actually put into practice. And it's a mindfulness skill that takes a while to really integrate. But putting those 5 minutes aside at the end of your day to really pay attention to what you're feeling and thinking, and how what you've worked on today has impacted you, and letting yourself kind of sit with that or kind of try to work through that is super important. And it can just be 5 minutes a day. But if you're not checking in with yourself on a regular basis, things are going to continue to build up. Like your stress level and all of the vicarious trauma that you've experienced is going to continue to compound. And that is a good way to get burned out. And so just, yeah, taking 5 minutes at the end of the day, shut off your phone, don't talk to your partners, sit in silence. Maybe you have to do that in your car. Uh, just taking those 5 minutes for yourself is important. Something else is that I always encourage people to, of course, like seek their own therapy. This is difficult work that we do. So seeking your own therapy and also getting good clinical supervision is important, so that we're not just going through the motions, but we actually are being very thoughtful about the work that we're doing. And also knowing that we can only do so much, that we can never make everything perfect or correct all of the social injustices in the world, but the more that we take care of ourselves and the more that we know and affirm that we've done everything that we have the capacity to do as an individual in that day, and being okay with that, is really also an important thing to do on a regular basis.
Okay, thank you, Mallory. So I have one comment. Do you have any tips trauma-informed case management while virtual?
Yes. So something to definitely always do when, especially with using telehealth, is to check in with that person and make sure that like where they are, that they feel comfortable talking. Sometimes people are not in a safe place to talk, or other people can hear them. Also, trying to support them if they don't have a lot of experience using technology, seeing if there are ways that you can maybe even send them something in the mail, so that with like pictures of how they can go about getting on telemedicine through their phone or computer, and working with them that way. Or even if they're talking to you on the phone, trying to ask them what would make them feel more comfortable, because it can be a really impersonal and anxiety provoking experience for some.
Thank you, I appreciate it. So there's not any additional questions that have been presented at the moment. I wanted to share, if I can, is to let everyone know that the training materials today, if you've registered for it and you're in attendance, you should receive a follow-up email with the recording information, and of course the slide information as well. Inside the actual chat box or the questions pane, there's the survey link. So if you can complete the survey for us and give us some feedback, we appreciate it greatly. Mallory, I don't know if you have any final thoughts that you wanted to share as we're wrapping up.
I know that this it was not ideal because I like to make trainings interactive. So if you really are struggling with like how to handle a situation with a client or something, or you feel like I can't really put that into play with my clients, I really am happy to talk to you and like brainstorm or work through, help like you work through a situation, to try to really make it a trauma-informed experience for the clients, and to think of ways that you can improve service delivery. So feel free to reach out to me if you have anything even like that.
Okay. So thank you, Mallory. And in the email that I'm going to send up, the follow-up email with some of the information that you presented on today, I wanted to share that I will put your information on it as well, CC you on it, so that everyone can have your email.
Okay, that sounds great.
Okay. So there is something else. Someone asked if the link is going to be part of the survey. You can also copy and paste the link into the actual browser. So I'll try to include it in there, but absolutely, yes, I think we try to do that. I try to get as much feedback immediately as possible. So I always provide the link in the chat. So then that way, if people don't have to necessarily wait for the follow-up email that may come to you on tomorrow or the end of the day on Friday. So I wanted to always make sure that everybody has access to the link at the beginning, during the presentations. So thank you. So Mallory, I want to say thank you. We really appreciate it. Thank you for joining us on today. And thank you, everyone. And we'll see you next time on our next webinar experience. Thank you.
Thank you.